Breast cancer is increasing worldwide. The proportion of young women younger than 45 years old is about 19%. However, based on Korean breast cancer, the proportion of young women for these patients in Korean breast cancer registry is about 30%. Recent SEER database, still you can see the more mortality in young women represented in orange bar compared with other standardized aged women. How can we preserve fertility for young women with breast cancer? Today, I'd like to address why young women matter regarding survival and prognosis, and then introduce fertility and pregnancy, and then discuss about real-world barriers and overcome of these and future direction. 30, 34 years old single woman who had palpable breast cancer diagnosed T2N1 breast cancer should receive the neoadjuvant chemotherapy and surgery, and she anticipates to receive 5 years of endocrine treatment. She married 1 year after surgery, and she decided to interrupt endocrine therapy for pregnancy. However, 2 years after, she still have difficulty to get pregnant. Now she is concerning returning to treatment, or she is safe to keep trying to pregnancy. The breast cancer is increasing worldwide. The proportion of young women younger than 45 years old is about 19%. However, based on Korean breast cancer registry database, there are more young women. The proportion of young women for these patients in Korean breast cancer registry is about 30%. The poor survival in young women it was historically reported. However, with more recent SEER database, still you can see the more mortality in young women represented in orange bar compared with other standardized aged women. So there are many studies that reveal about the poor survival in young women. However, we could find out that amenorrhea is associated with improved survival. Therefore, the studies of adding ovarian function suppression to tamoxifen had started since 2003 in Europe and 2009 in Korea. And most of those studies consistently reported survival benefit of adding ovarian function suppression for young women with breast cancer. Therefore, probably the young women, so this survival disparity has reduced in the future with more longer and efficient endocrine treatment. However, the young women should face about their future ovarian dysfunction and fertility issues. So still, young women's breast cancer survivor has reported 60% lower chance of getting pregnant compared with other standardized age women due to chemotherapy, extended endocrine treatment, and concerns about cancer recurrence. However, the young women's food study showed that 36% of young patients reported interest in pregnancy within 5 years after breast cancer diagnosis. How can we preserve fertility for young women with breast cancer? We can consider ovarian function suppression who anticipate the chemotherapy to preserve ovarian dysfunction, and more actively the patient can choose ovary embryo or ovarian tissue cryopreservation before the treatment. The patient who receive ovarian function suppression while chemotherapy, the ovarian preservation rate and pregnancy rate were doubled compared with the control group. However, there are concerns about fertility preservation, including safety of breast cancer treatment and treatment delay and success rate, and also the medical cost. Fortunately, the fertility preservation procedure and ovarian function suppression concurrent with the chemotherapy does not show lower survival compared with the control group. And also the patient who get pregnant after breast cancer diagnosis, even though this kind of a study cannot be prospective randomized, all these studies are retrospective. There are some healthy mother effect bias. However, most of these large-scale studies show that similar survivor compared with the non-pregnant cohort. And also the long-term safety report of controlled ovarian stimulation for escaping high estrogen stimulation for fertility preservation has been reported. And to minimize the treatment delay, random start ovarian stimulation has reported outstanding and safety data. Let me show actual process of the oocyte retrieval. This patient starts ovarian stimulation on the day 12 of menstruation cycle. This is independent of her menstruation. The egg retrieval occurred on the day of 12 of ovarian stimulation, and the patient received aromatase inhibitor for minimizing estrogen hyperstimulation. And patient anticipate chemotherapy, therefore the patient received GnRH agonist after egg retrieval for minimizing ovarian dysfunction while chemotherapy. And recently, the positive trial reported early safety data who interrupt endocrine therapy for those who already received 2 to 3 years of endocrine treatment compared with the control group. The control group was composed with soft and text the patient. And also, if the patient interrupt endocrine treatment, however, the patient still has a difficulty of getting pregnant. Probably the patient uh, really afraid of their recurrence. Their Azim and their colleague reported that the patient age and also fertility preservation at the time of diagnosis increased pregnancy rate almost 2.4 times more compared with the control group. Therefore, from the positive trial, we can once again recognize we should start fertility preservation and the pregnancy counseling at the time of breast cancer diagnosis. When patient visit the outpatient clinic, we should discuss about their the patient breast cancer treatment and also discuss about future ovarian dysfunction and fertility issue and viable options of fertility preservation, including embryo and oocyte cryopreservation, and if possible, ovarian tissue cryopreservation. And if patient anticipate the chemotherapy, we can consider ovarian function suppression to preserve ovarian function for those patients. If patients have plan for pregnancy, we can also discuss of option of interrupting endocrine treatment considering the patient age and the severity of a patient breast cancer. And embryo transfer can increase the chance of a pregnancy, so we can actively positively consider the ART during interrupting of endocrine treatment. However, there are still barriers, and how can we overcome this? In real world practice, in real world situation, the patient who diagnosed breast cancer in their younger age when patient visit the clinic, the fear of breast cancer and fear of treatment delay, and sometimes the patient never think about their pregnancy before visiting hospital. Probably fertility, those words are not familiar with the young women. In doctors' side, especially in Asian country, including South Korea, very busy outpatient clinic and difficult to connect with multidisciplinary clinic and also like fertility specialists, doctors, and lack of supportive system. All these kind of barriers make difficult for effective fertility counseling, and patients hesitate to do their decision making, just give up, lose their chance. So there are many kind of these barriers. From patient side, decision conflict are one of the big issues. The patient hesitate, the treatment just go straight, the patient lose the chance to receive fertility preservation. In doctor's side, the doctor's attitude and time constraint and lack of a supportive system and no referral doctors are major barriers. Let's look at this survey result. The patient, 300 medical oncologists in United States who enrolled their patient in soft and text trial. and who has willingness to open their patient on positive trials. Therefore, 97 more doctors answered they refer and discuss fertility issue with the patient. However, more than half of doctors answered they still has discomfort of recommending women to stop endocrine treatment. And the survey showed that um, the doctors still think about the breast cancer treatment is more important to fertility treatment. And the patient who had severe breast cancer, they had still discomfort to discuss about the fertility issues. And this is the Asian survey study, including Korean Breast Cancer Society and Asian Breast Cancer Network meeting during GBCC annually held in South Korea and Latin America medical colleges. The main barriers are the time constraint, and second one is no referral system, and other issues are the treatment delays. And there are the policy issues. And let's look at this survey and also this study. Matteo and colleagues reported the patient who diagnosed breast cancer in their younger age and also BRCA mutation. The pregnancy rate at 10 years were 22%. Asan Medical Center also put our data into this study. However, the pregnancy rate in Asan Medical Center was only 10%. Why this disparity exists? This survey showed that on the left on the left side, even though the patient found out they have a BRCA mutation, they still consider prenatal diagnosis or pre-implantation genetic test. However, in South Korea, prenatal diagnosis are not allowed. Therefore, this survey conducted in Korea 70 more patients, 70 more women were the partners considering the future baby, and they have still willingness to marry with their the couple, even though she diagnosed breast cancer. However, about 30% of couples they decided to not to have a baby if her or if the woman or the partner will be diagnosed with breast cancer. And across the country, lack of insurance and financial burdens are major issues, are major barriers of fertility preservation. And in some countries, lack of a supportive system and time constraint are major issues. So how can we overcome all these barriers? So let me show the clinical trial conducted in Italy and Europe paper study last year in San Antonio. Dr. Matteo Lambertini showed safety oncologic data who received the fertility preservation in preferred study. In South Korea, there is MyBC study, a multidisciplinary approach in young women with breast cancer. And we compare usual care group and shared decision-making group. For usual care group, the patient receive usual consult according to doctor and hospital policy. And shared decision-making group, we develop a counseling program and patient receive those kind of counseling. Primary endpoint is choosing fertility preservation, and second outcomes are pregnancy and satisfaction, decision conflict, and survivor. And we have a plan to generalize all this survivor program into South Korea. And when patient visit the clinic, we discuss about the future fertility and pregnancy issue, and patient have a willingness to conduct these options. We refer to fertility specialists. And fortunately, 2 weeks ago, we finished the enrollment, and 11,000 of young patients were enrolled in my business study. And also, we enrolled retrospective 5,000, 100 patients. And also, every single patient, we collect uh, 1,000 more data. And we collect the patient PROM database, not only patient but also the partners. And we develop the decision making program using the for education. using leaflet and education video, and we developed website for decision aid. This is a leaflet and education video, and patients can go to online decision aid program. They can review about their knowledge, and they can consider what is their preference and what is the conflict of decision of all these programs. And for this program, patients are very important, and patients participate this study as research partners. So we develop policy advocacy for patients. We change some other policy in South Korea. So the patient and also the patient participate as research partners also. This is the education program for patient advocacy about the monthly webinar. And some patients, the young patients, they do not want to open their cancer diagnosis. And it is very difficult to leave their workplace often and long-term travel distance. For overcome this limitation, we did a metaverse symposium for young women who is very easy to connect with this new technology. They can create their own avatar and participate in the symposium, metaverse symposium. So from this study, patients can participate not from the patient to participant for this patient-centered trial, and not only one episode to like a continuum of these trials. So why young Asian patients are unique? Because they are digitally fluent and they are in the middle of a major life transition and long-term survivorship ahead. If the patient receives 10 years of treatment, they are still younger than 50 years old. And there are very clear unmet needs, including fertility, identity, parenting, and return to workplace. Let me show some the patient advocacy crew. This is running crew. We call the Bougie Run, Breast Cancer Go Run. So spon- uh, they run offline and online by themselves. And this is the climbing crew, and they share their experience to other people for encouraging their treatment and share this the treatment procedure and process. And some young patients who still hide and their treatment and more uh, try to open their treatment into the world, and they take tamoxifen together at the same time. So in Asan Medical Center, there is the Young Breast Cancer Multidisciplinary Clinic since 2010. So for this MyBC study, we try to generalize this system beyond Asan Medical Center in South Korea. And last year, we also create My Hope program. It is for uh, young people with all kind of cancer. So we create this program beyond breast cancer. And we already published many papers using retrospective cohort and also participate many international young breast cancer program. And we published a study on barriers of fertility preservation in young women and patient cases report and did a policy session. And last year we did pilot program to financial support of fertility preservation for young cancer patients and try to collaborate with other countries' young women's study. So in the future, we should make we have planned for whole journey of pregnancy, not only fertility but also the pregnancy and after pregnancy and children and their parenting. And also we need whole journey of life course oncology in young women, not only fertility but also survivor long-term medical complications using digital and translational research programs. And long-term comorbidity for young women with breast cancer using government database and patient PROM data. And patient-tailored education contents on right timing and right education, but using right time education materials. So if 34 years single woman, if she think about her future plan more seriously or actively, if she can preserve uh, her the ovary before the treatment, and after receive the treatment, and if she decided to stop treatment for pregnancy, if there are more supportive system for her treatment, her life may be changed. This is the interview who interrupt the treatment, but at that time they had the difficult to get pregnant, but this year they have a baby. At that time, they told us there's just one simple hope of this year is they dream just simple life and with very small precious moment, and they have a baby this year. So importance of fertility preservation counseling is emerging. We already know that considering age and type of treatment and duration and patient preference. However, in the world, there are still many barriers. However, we should do all our effort for improving our medical situation better. So for young women with breast cancer, life course oncology might be important. Thank you for all your attention. And I really support all young women with breast cancer. They have hope have a family and their future. Thank you for your attention.